And joining us on the podium for this panel discussion are Lucy Nugent, CEO of Tallaght University Hospital. Audry Deane is a management consultant, non-profit board member and programme mentor with Sláintecare Healthy Communities. A big welcome back to Brian Dolan, Director of Health Service 360, and also joining us Tony O'Brien, Leadership, Governance and Strategy Consultant, Business Post columnist and former Director General of the HSE. Give them a warm welcome, please. So thank you and good to see you all. And don't forget to send in your questions and we can put them to the panel as we go. This panel is talking about taking stock and leading change. Audrey, will you kick us off and tell us where you believe, or if you believe, that we're seeing change in our health system?
Well, I have to say, I have to respond to what I heard this morning from the Secretary General. I will get to your question, Audrey. But I have to say, as a citizen and taxpayer, I was quite frankly outraged to hear the Secretary General say that most people have a good experience of the health system, because that is patently not true. And I wanted to disrupt, which would have been very rude, so I held myself back, but I'm not going to hold myself back now. 20 years ago, I trotted in and out of the Department of Health as the representative of the St. Vincent de Paul Society, which is based here in the North East Inner City, and began the dialogue about health inequalities, and came and worked and respected and was honoured by lots of fabulous people who are still within the department. But I have to say, 20 years on, to sit and listen to, the Secretary General say that, it seemed to be quite, at least an abrasive, if not a quite ill-informed comment. And I'm actually surprised that nobody took him up on it. So I am taking him up on it. And I am outraged by that comment, given his position in our society. Now, I'll move on and I'll just vent, and it's over, guys. We can move on. There's great stuff happening. Sláintecare Healthy Care Communities, people might know about it, but it is a tiny spark of innovation, and it's a story, Brian, it's a lovely story of people actually being hosted within local authorities, working in the 19 most disadvantaged communities in this country. But they go out, they consult, they listen, and they engage with the communities that we really want to connect with. And we're talking about deep and very, very stark health inequalities in this country, which are shaming, absolutely shocking and shaming. And they go and talk and hear the stories and find out what these communities need and want. And sometimes it isn't, you shouldn't drink, you shouldn't smoke. It's actually, the playground is full of dog shit and syringes and I can't go there with my toddlers. Or there may be an absolute dearth of resources. And these communities are living in situations of sheer deprivation. So what I want to say today is that there is innovation. You can see it in the local authorities who are active in this programme, and the officers who are working based in the local authorities are galvanising and capturing the resources of the local authority to start tackling the causes of health inequalities. So that aside, that is a good look story, but that is a tiny piece of collaborative muscle. But we've got to build that across the systems, because actually we've got so many operating systems. We've got, 6 hospital groups? We've got 9 CHOs, and we've got the Children's Health Hospital, and they are all, there is no one oversight, governance, accountable person for all of them. So how can we actually drive change if we can't actually sort out the fragmented systems? And that's where we've got to start. I was actually getting quite fatigued hearing the same stories about the lack of data. I mean, Sarah spoke about the Joint the Rock This Committee. If you go and read through the pages and pages of that, and it is on public record, you will hear some dreadful stories about the gap that lack of data does. If we can't track a patient from a GP referral through a procedure and out the other end back into their home, Brian, you spoke about homes, and that was so lovely. You didn't talk about hospital stays. If we can't track that expenditure, never mind the patient outcome, we're in deep trouble. And we are in deep trouble, despite the advances that COVID gave us. So fragmentation, siloed activities, these are actually killing our communities. We had Avril Power from the Irish Cancer Society last week talking about the 28% differential between people living in the poorest areas and those in the most affluent. We all know this. We all know this. Our health inequalities are shocking. They should shame us into breaking out of the fragmented, siloed communities in which excellent clinicians work. But after hearing the level of blasé, abrasiveness of this morning, I'm quite upset about it actually. But I want to hang on to the good stuff, which is that we have passionate people who care. But let's remember that we have a hybrid, bizarre model in which the eligibility still functions as a way into the system. We have not managed to deliver Sláintecare. It's out there now quite a long time. We haven't managed to place entitlement to universal access to care in this country. And I've been going in and out of the department since 2000 talking about those things. We're now in 2023. So I'm sorry to say I'm being a disruptive and rude
Not at all.
but
Not
I'm
at
sorry,
all.
I'm hurting after hearing those comments that went unchallenged by everybody in this room.
Audrey, thank you. Tony, from your expertise and insights, what change are you noticing in our healthcare system?
Well, good morning everybody. I think it's important to acknowledge that the level of change isn't where any of us would have expected it to be in 2017. And partly that's due to intervening events. Partly that's due to the fact that the level of ambition articulated by the Slaintecare committee was enormous, but wasn't really backed up at that point with an implementation plan. But below the surface, there are quite a lot of interesting things happening. So the Enhanced Community Care Programme is beginning to do things. We're seeing significant changes around eligibility, not yet to universal level, but the reduction, for example, in the eligibility thresholds for GP visit cards, GP cards, the monthly co-pays on the drugs reimbursement scheme are having a real and material impact on people's access to healthcare. But what we haven't seen is some of the more fundamental changes that are required to bring about the vision that the Slaintecare programme set forward. And the reality is that at the current pace, we won't get there. So there does need to be a step change. Things like the consultant contract are important. Things like the significant degrees of recruitment outside of the hospital system in the community space are really important. But we do have this fundamental problem that we have a significant backlog of required elective work. People waiting for diagnostics, people waiting for admission for procedures in the public hospital system. And unless there is a step change in that is going to effectively act as a millstone around the neck of the health system while it's attempting to reform. So it's around how we use the totality of the healthcare resource in the entire state to address that need, which gets us into the whole public-private discussion, which we'll probably come to.
Lucy, from your perspective, what change, if any, are you noticing in our healthcare system?
I think there's a lot of green shoots. I think the problem is that we're not communicating and celebrating those successes. So, back in 2019, there was the Slaintecare projects. It was a call across the entire health ecosystem and social care and the public. If they had an idea that they felt would impact on the health of the population, come forward. And I know in our hospital we had 4 projects. They were very successful. They were based out in the community. They were nurse delivered, and they've now been mainstreamed. But I was chatting to a colleague, and they didn't know about one of our projects, which they're thinking of replicating. And I'm going, well, we've all the learning. So at one point, there was meant to be, if something is successful, it should be scaled across the health system. And I think we're missing that element of it. I think the communication regarding the incremental improvements and the journey towards Slaintecare aren't being, if I stopped somebody in my hospital and asked them about the regional health areas, they go, yeah, that's something that's happening in a configuration. Is it going to change how I do my job? Well, actually, if it works, it should, because, there should be, for example, if you're a physiotherapist, if the patient has finished their acute episode of care but need ongoing support, they should be then, the community physiotherapists should know about them. And really, I take it very simply. If you take the patient journey and follow the patient journey and look at the supports they need in place, it de-silos health completely. And that is happening slowly. For example, there are now, near our hospital, there's community diagnostics. So there's a radiology centre. It's clinically run by our hospital, but it's actually a facility run by CHO7. So collaboration, conversations, it breaks down those kind of walls which we traditionally have lived in. So I'm maybe a bit more optimistic. I think there are green shoots. I think Tony's right, though. It shouldn't be an us and them when it comes to the private health system. There is a role for all of us to play. The private health system has 2,000 beds that we need at the moment. We don't have enough beds in the right places. I think we talk a lot about bed capacity, but it is making sure that you're putting the beds in the right place and the right type of bed as well. I could keep going on, but I won't.
Brian, you're welcome back, and thanks for joining our panel. You talk and have spent much of your career dealing with culture change. How difficult is it to change a culture that has been embedded for decades?
My first thought is never waste a crisis. And we saw during COVID, I got stuck in New Zealand. I could get out of New Zealand, couldn't get back, so I didn't see my son for 2 years. And what we saw all over the world was incredible innovation at pace. And I think one of the things we need is COVID guardians, because their job is to protect all the good stuff that happened and not let it slide backward. And that includes building trust. And culture, I think we sometimes get unduly occupied by the anatomy, which is structure, whereas the physiology of organizations is the people and the process. And so often what we do is we go off on these massive big projects. Now, notwithstanding EPR is a big project, but so often what you do is there's big meetings, they're having Gantt charts for Africa, there's project plans, and on the morning of the first launch, you know, the dog on the street can tell you that it's not working, but by then people put time and effort and ego into it. Whereas picking on Lucy's point, actually small-scale stuff actually has a profound impact because it means that people feel trusted. And I think a leader's job, real job, is they are the director of permission giving. That's what their job is. I was an exec director in the NHS. I'd say to my team, if we only make 20 mistakes a day, that's a good day, isn't it? What have we learned from that? Now, obviously, there's a boundary, which is patient safety, but no one comes to work to do deliberate harm. They come to work, but what they want to do is feel trusted and given permission to make it better. So I was in Jersey last week, and we run a program called iCare, which stands for Innovation, Compassion, Attitude, Resilience, Engagement. And you watch these women and men over a few minutes just blossom. And one of them said, that woman actually is from Cork, she says, we started feeling angry and defensive. We now feel cohesive, trusted, and hopeful. That's what culture change is. It's something intrinsic. It's a bit like love. It needs two people for it to happen. And it's like trust. And trust is the lubricant of organizations. Because a team without trust is actually just a group of randoms who are co-located. So the most important thing you do is build trust. And that means having leaders who are highly visible. Every GM of every hospital should walk through the emergency department on their way to work every day, not just occasionally. And it doesn't mean you have to have an answer, but it means that you know what's going on. People see you, they can listen, they can rant. And as many times people said to me, I don't need an answer, I just need a rant. Just giving people a safe place to offload, those are the things that make it visible. And the last thing I'd say is this, keep the message simple. You know, I can't imagine any patient saying, geez, I can't wait to go to CHO7. You know?
Thank you, Brian. Audrey, is that trust there in our system? I'm wondering, have we unleashed to its full extent the power of local or regional leadership in our health service?
That's a very good question, and I want to start with what Brian said, because it is about emotional intelligence in leadership. Excuse me. And there are such amazing leaders at every level. And I'm thinking particularly of the local development officers who are part of the Sláintecare Healthy Care communities. They are leaders. They are in the rag and bone shop of extremely disadvantaged war-torn almost communities, and they are listening and showing emotional intelligence. I'm off mic, sorry. And they are showing by being there, by their presence, that they respect the journey that the people in those communities, who, by the way, have no expectation. They have zero expectation. They are at the behest of the largesse of the public health system, which is not delivering for them. We know that. But the little beacon of light is that these officers are a broker and a bridge, and they are hearing, listening, and translating that, and using, to get to your question, Audrey, they are using their ability to be emotionally intelligent leaders to go back into the local authority and drag the engineer or the architect or whoever it is they need to be getting on site to start releasing resources and synergizing and leveraging a result, an initiative which actually makes sense. Without naming communities, the Sláintecare Communities project has put in play therapists in situations where there are very, very damaged young children. And these young children are unfortunately the recipient of severe adverse childhood experiences. Play therapists sitting in the sandpit, doing the stuff, and the fantastic responses back from those teachers. These children are coming out of themselves. These are little pockets and little incremental moments of magic. And as human beings, we can do that for each other. And especially disadvantaged youth, particularly in regional, rural areas, a very, very, very deeply disadvantaged community, and particularly during COVID, they lost so much. All the milestones. I have a 20-year-old myself. There was a lot of sitting in his room. I didn't see him until it was a mealtime. And he was a lucky child. He had access to resources, loving parents who could hopefully, do something. But these communities are holding and putting their arms around these young people, and they are showing leadership, and it's pulling up leadership from their communities. And I think that's what it's all about. So if we can listen to these people within the system, wherever they are, it may be horizontal, lateral leadership, but it's about also finding the coalition of the willing. And we all know what that means. We all know that sometimes it isn't the chief engineer, it's the fella who does the Excel spreadsheets, who knows everything about every playground in Dublin North East Inner City, and he's the one to go to ask who you should be talking to. So as long as people want to work together and do not get paralysed by the inertia of the system, which has actually, it is not dismantling the siloed fragmentation, I'm sorry to say. It just isn't. So we do need these leaders who are brave and who find like-minded souls in the rag and bone shop of the heart, which is, as you said, the physiology of the health system. So Brian, thank you for giving us these images.
Good help.
Tony, what's your view on this? Does the HSE trust regional, local leadership enough?
I think there is a structural problem. There is a connection between physiology, structure, and formal accountability. One of the things I recall from when I was Director General was a thing called the Values in Action programme, which sought to empower what we would call backstage leadership, locally selected leaderships who are championing small-scale projects designed to bring out the inherent values of the health system by doing things locally. And it was very clear that when given the potential to do that, there are many people willing to step up and lead in difficult circumstances throughout the healthcare system. And I think we also saw that during COVID. And while many of the national things were centrally directed, their implementation was very much powered locally using short decision-making time spans and quick implementation processes. Interestingly, Bernard Gloucester, who will shortly be coming in as the CEO of the HSE, was one of the champions of Values in Action in his region when he was leading community health in the Midwest. To come back to the structural point, and Robert Watt mentioned earlier his celebrated appearances at Oireachtas committees, there is a formal system of accountability which, unless it is properly devolved, for example through the creation of the RHAs as real entities, it will continue to drive a process where some individual or some small group of individuals at the very top of the HSE will be held publicly accountable for everything through the Oireachtas committee process, which will drive organisational behaviours that are by nature disempowering. So unless there is a legal basis for authority to be devolved properly to these new RHAs, one of my fears would be that nothing will actually change, that we will simply have HSE Mark 3 or Mark 4 rather than real change. And having been that person, there is a reality that when you are held personally accountable in the public glare, it does drive your agenda and the information you want, the level of control and assurance you want. And by definition, that limits freedom of action, delegation, authority, and the power to innovate at local level. So I think this is a really important part of the whole journey towards Sláintecare. Are we really going to devolve decision-making within the health system, or are we not? And there's only one shot at this, and I'm concerned at the moment that it isn't really going to happen.
Teresa Barry has sent in a question. Lucy, perhaps you would pick up on this, and it's following on from what we're talking about, how you think the HSE and the department are doing with leadership. Is it more top-down dictator style than leading by example? And as Tony was saying, devolving that power outside of the main authority. What do you think, Lucy?
I suppose, with the exception of 6 months, I've spent my entire health career in the voluntary hospital sector. So I only lasted 6 months in the HSE, so that might say a little bit about my own mindset. I think the Department of Health and the HSE, I think, are grappling with what is their role in the new system of regional health areas. And I think it's something that somebody is going to have to give. And it is about, going back to that point earlier about trust, are the CEOs of the regional health areas going to be trusted by the HSE Central? And the HSE Central will have a function. And again, it's about clearly defining what that function is. So, for example, the national clinical programs, which have been very successful, again, about improving the health of our population, they will still be held centrally. So if you go to Portlaoise or you go to Mullingar, you will still get the same standard of care if you're a diabetic, etc. So I think it is about the department also clearly defining what their role is. Is it about policy, or is it actually getting into oversight of the regional health areas? I don't think those questions have been answered at either HSE or department level as of yet. But the clock is ticking. At the moment, the provisional date for the standing up of the regional health areas is January 2024. So it's less than 11 months away. And again, how's that being communicated?
Brian, is there evidence that when decisions are made at a more local leadership level, that they do translate into better decision making for the patient?
Yeah, absolutely. I said earlier about keeping the message simple. So I went to Christchurch, to Canterbury, New Zealand, for Christchurch, for 5 weeks, and that was 17 years ago. It was obviously a very Irish 5 weeks. And the message for Canterbury, which is everywhere, is this: make it better. Now, the power of that is it's a call to action, and it's also an opportunity to make stuff better. So what you get is the GPs working with the orthopods, looking at back pain and creating a path. I mean, when they've agreed on this, there was white smoke coming up the chimney, And it's when you trust, and if you, I think a good way of doing this stuff is start with the patient and work backwards. Don't start with the health system and work forwards. The strategy of Canterbury Health System, and now it's been evolved, and there's a new national New Zealand health system, Te Whatu Ora. But the Canterbury model, the whole strategic, it was a picture. And in the picture, in the center of that picture, was a person we called Agnes in her home. And in concentric circles, then you had primary care and tertiary care. And at the outer edge were the cathedrals of Technocure, which are the hospitals. Because that's what life should be about, not let's design it around these glorious Technocure environments of the hospital. Let's design it around somebody called Agnes, or we might call her Bridget here, and work outwards. And then you trust people to make it better. But Lucy's point is spot on. if you don't trust local leaders in the local context to do what is right, then it starts to unravel. But the last point I'd make is this, and this is about all systems, having the 3 Ps. The purpose, which is what is our connected why, the plan, which is our how and our what, and then the people, which is the responsibility. So purpose, plan, people, because when people know who's got to do what, then you actually have greater clarity. Clarity of purpose, clarity of plan, clarity of responsibility. And we don't talk about that nearly enough. So what we end up in is this kind of, you end up with these islands of excellence in seas of mediocrity. And we don't need that.
Tony, from your knowledge of the HSE, we have a comment in here from someone in our audience saying, how can we protect the rapid pace innovations and trusted use of staff knowledge and ability that flourished during COVID within the HSE, because it currently seems to be moving back to a national command and control, which in effect is paralysing. From your knowledge of the HSE model and how it works, how difficult will any culture change be?
Well, culture change is obviously always the most difficult thing, but I think we need to look beyond the HSE. The reality is that many of the decision-making processes are not within the HSE's control. So the HSE, through its management team and its board, will seek to do the right thing often, but will then have to go to the Department of Health to get SIT sanctioned. That department will have to go to the Department for Public Expenditure and Reform to get its sanction. That sanction can take forever. You know, that we've had a wonderful plan for e-health since 2013, but it's never received all of the sanctions it needs to be implemented. And from inside the HSE, I know from having, before I was DG and while I was DG, it often looks like it's the HSE that's primarily the roadblock. But most of those critical policy funding decisions are made elsewhere. And this is where the point that Sarah made was really clear. It's not enough to have the Secretary General of the Department of Health or the Minister of Health committed to the extent that they are to the plan. The Slaintecare Committee recommended that the Slaintecare reform programme should be led out from the Department of the Taoiseach. That has never happened. And some of the issues that you mentioned earlier, Audrey, about the community issues, you cannot solve the health of the nation from within the health system. It's an integrated piece around the way we plan our housing, our public spaces, the way local authorities give access to recreational facilities and so on. It's much bigger, but even within the health system, many of the decisions that you would expect in the private sector, the CEO and board of the HSE to be able to make, they simply cannot make. Why is there no service plan published at this stage in the middle of the second month of the year? Presumably, it's because the HSE hasn't got the necessary sanction from government to publish that plan. When that plan is published, it will not be a plan that seeks to meet the healthcare needs of the population this year. Even if it's fully achieved, it will be a plan to fail to meet the healthcare needs of the population this year. And that's not something that people anywhere in the HSE would wish to do. That's the reality of the context in which they work. So we need a cultural shift that is much bigger. It's around the level of ambition that we have to have a healthcare system that day in and day out can meet the healthcare needs of the population by whatever means we seek to define them. In many countries, you couldn't publish a service plan that didn't at least seek to achieve a reasonable standard of care. And when we've seen what we've seen in the emergency department since Christmas, it is a clear example that the system is not currently engineered to meet the needs of the population it's trying to serve. When you've got 1 million people on a waiting list for a diagnostic or interventional procedure, it's a clear statement that we do not have a plan to meet the needs of the population as they stand. And I think it would be wrong to see that as resting solely at the door of the people who lead the HSE, because that's not where the ultimate roadblocks are.
Brian?
Thank you. I may just briefly pick up the point about the engineering. I think actually our systems, and it's around the world, by the way, the only change that happens, the only thing that's different in healthcare is the accent, wherever you are. Everywhere is uniquely similar, to be honest. But actually our systems are designed to have people waiting for appointments. It's designed to have people waiting in the back of an ambulance to get to ED. It is designed for people to be lying in a corridor to get into a bed. It is designed for them to be going out at 6 or 7 o'clock at night. It is, because if it's happening every day, it has been designed that way. It's terrible design, but it's designed nonetheless. and it is design that we see everywhere. And it circles back to the structures, the cultures, and Tony's point is so right. We shouldn't be pinning it on individuals. We have a collective responsibility to address this, as is all of us. But we have to people to feel that it's not okay what's going on. And I can't fix all of it, but I can fix this bit of it. And when people feel trusted to fix the bit, then that's when we get the collective gains that we desperately need. People deserve the best that they can get, and we can enable them to do it.
Lucy, what are your thoughts on what you've been hearing there from Tony and Brian?
I think it's interesting that, it's always someone else's responsibility, whereas we're all part of fixing the system. And, we're facing a lot of challenges. We've spoken earlier about, the health workforce and the gaps that are going to be there. So, how can we work smarter? We do it in our personal lives every day, but, we have been slow to adopt technology. The pandemic was brilliant for that. But again, I think when you have good clinical leadership, it's those small incremental improvements. It's how do you create and scale that again? But I think I'm a bit more hopeful, but I think we need to work smarter because we are going to face a shortage in healthcare workers, be it because we're not training enough, be it because they're leaving in their droves to sunnier climes, be it that the cost of living in the city. Housing is a huge issue. People are deciding to work where they can actually, have a home and raise a family, and that may not be in the large cities in this country anymore. And how do we counterbalance that? So I think we need to focus on the patients and empowering them, because there's plenty of scientific evidence that says if the patient is basically the conductor of their own care, their outcomes are better. I think we're still very paternalistic, so I think we need to have patient empowerment, and we also need to look at our workforce and mind them. And if someone has a good idea, foster it. We have in Tallaght University Hospital, we have an innovation hub, and on a Tuesday and Thursday morning, any member of staff from the porter to the consultant can come in with an idea. And it could be a challenge, or it could be a solution, it could be an idea. And they're supported through that ideation process to either, something, there's a solution already out there, we'll get it for you, make your working life easier. Or let's work together to see, can we actually work this up? And I think, number one, we're doing it because it's the right thing to do. But number two, you have a workforce that then is motivated to come forward with solutions. And I think we need to do more of that. We need to foster that inquiring mindset. Which I think we've lost along the way because I think people are just so busy just trying to get through the day-to-day pressures of work. And I think we need to take stock of that as well and foster it.
We'll be discussing specifically the recruitment and retention of staff in about an hour's time here. Audrey, I want to spend a few minutes talking about private healthcare. And I know access is a huge issue, unequal access to our healthcare system. I think it's 60% and growing of the population have private health insurance. Now, that's not what the plan is, according to Sláintecare. It's the opposite. But do you think we will always have private healthcare here, and should we always have private healthcare?
That's a really hard question. The OECD did an economic survey of Ireland that was published mid-December, and it gets into the underbelly of just how complicated it is. I'm not a health economist, so I have no desire to inflict my half-formed views on anybody here, but there are different ways of doing it, and I believe Canada is the only country, I could be terribly wrong, I'll admit that now, that has totally unravelled private from public. But to me, in this country, we have such a hybrid, bizarre model that people accept it. The passivity around it is, to me, quite shocking and has been for decades. So I believe it is almost at a symbolic level that we need to follow through on the de Butler report, which is a very complicated and complex report, but very well written. And the slowness and the pace of that, to me, is just dire. And in the meantime, people are dying from health, unequal access to care. So for me, I'm actually a bit worried that the Irish population hasn't really ever had the think around what do we mean by universal access to care? Is it worth funding properly, and what that'll mean? We all love to queue up to give out, as I did. I vented from the privilege of being on a platform about somebody's comments about the public health system. But we vent, but we don't do that bit of thinking, which means how are we going to fund it? And in the meantime, we accept the largesse of the public system or the fast tracking of the private. So to cut all that drivel short, what I want to finish on is by saying that for me, the heroes in all of this, to just jump a little bit, are the middle managers in health and social care services in the community and primary sector, because they are at the hard edge of it all, and how they get up in the morning and motivate themselves to get into work and motivate teams, which Brian, you touched on, which is all about humanity and modelling emotional intelligence. I don't know how they do that, because the system is crippling them and it is crucifying both them and their patients. So for me, I would love to see a loosening up of incentivizing middle managers to do something about the burnout, to recognise it, to support them, to give them the autonomy to do that. And I don't see that happening yet. It is pretty well a race to the bottom. So I'm sorry, there may be some jumbled thoughts, but really, I think we need to grow up and ask some hard questions and put up with the delivery in the meantime, but really know what we want. Because if you ask somebody on Jones's Road outside, what would Sláintecare do for you if it was delivered tomorrow? They wouldn't be able to tell you.
Yeah.
So if we don't understand it, we don't own it.
Tony, what's your view on the private healthcare?
Because I know we're short of time, my perspective is influenced by the fact I'm a child of the NHS, so I'll just say that up front. I think that the real issue is that too many people are having or feel compelled to buy private health insurance because they don't have confidence that they'll get the care they need in the public system. That's the first point. The second point is there will always be some kind of private provision because you cannot take away an individual's right to do that. Third thing is that in the Irish system, which is very different from the English system because of the numbers you've referenced, there is quite a lot of innovation that comes into our healthcare system through both the private providers, many of whom are currently working to address waiting list pressures in the public system, but also through the voluntary sector, which originally would have been called the private system. So over time, we've taken what was private, turned it voluntary, and then kind of, to the best of our extent, delimited their ability to innovate, although some of the voluntaries are still struggling to ensure that they keep that space. If you're a patient, I don't think you much care from an ideological perspective whether you get your care from a private organisation, a not-for-profit organisation, or a state-owned organisation. What you want is an entire system that provides you with the access that you need based on your clinical need when you need it. And if you want to pay extra to have extra this, that, or the other, or hotel services, you should do so. Right now, given the gap between our capacity and the demand that our population has for healthcare, I think we need to throw the ideology out the window and allow people access to care wherever they can get it, provided it meets the standard. We do need to have proper licensing and regulation of the entire healthcare system, whether it's public or private. But for the foreseeable future, we need the private system. What we need to do is change the orientation about how people access it.
Lucy.
Just one thing to, I was doing a bit of research into this, and I didn't realise that 85% of private health income generated in the public sector comes from patients who are admitted via the emergency department. Everyone thinks it's all about, the elective side of things. So 85% of that 400 million a year that the public sector earns is via the emergency department. So just to bear that in mind. And there is going to be a funding gap if we, as hospitals, can no longer charge patients via their health insurance for that. I don't think the private sector is the enemy. They're a partner in this ecosystem that we're trying to develop.
Brian, what's your view?
Quickly, obviously, but if you think about it, what people are buying when they buy private healthcare is they're purchasing a shortening of time. That's what they're really buying. Quick. So I'm not ideologically averse to private care. What I do have a problem with is, as that great North Sider Bono said, the rich stay healthy, the sick stay poor. And in an equitable society, a just society, everyone would have access where they don't get bumped off a list because others have the opportunities that they don't have. So that's my take.
Well, thank you all very much indeed for joining us here this morning.